I will be the presenter for today, and those are my names. Just move on. Now, that particular bit was tackled in the presentation. That's who we are, where we are located, what we do. That is for the purposes of disclosure in as far as today's session is concerned. Let's move on quickly. So in today's talk, my presentation will be on the following outline. We shall define, also rationalize the use of contraception, then how to choose the appropriate contraception for each person. We'll mention briefly on various contraceptive methods which are available. We'll touch on certain myths that exist about contraceptive and contraception, then conclude, and thereafter have a session of question and answer. So by definition, contraception means against conception. It's just as simple as that. And it aims at any measures that are taken to prevent conception, thereby enabling the woman or the couple to have babies when they want, if at all they want. It is synonymously used as birth spacing, family planning, or pregnancy contraception. It is good to mention that this concept of contraception is actually not new. So I might not, in essence, tell you anything new that you've never heard about. We are just trying to synchronize our thoughts. This contraception or birth control is a form of safeguards to ensure that maternal health is preserved. There are various methods of contraception, as we are aware of, and these methods have been developed over time. They undergo repeated improvement for safety and to minimize side effects. It is good to mention from the word go that there is no method which confers 100% success rate, except one method, which is basically not a contraception, called abstinence. Therefore, all contraceptive measures that we advise or that people take are likely to have some degree of failure rate. This is usually expressed as how many women out of 1,000 who might get pregnant despite using the contraception, either because of not using as indicated or other factors that may contribute to the failure. So we have different ways of looking at contraceptions or contraceptives. So we can classify them based on the duration or how long they are supposed to act. Thereby we have short-term methods, intermediate, long-term, and permanent methods, where permanent means you're completely removing the chance of the woman to conceive in the natural way. Secondly, we can also classify based on the contents, and thereby we have hormonal contraceptives and non-hormonal contraceptives. We look a bit further on these methods. So hormonal contraceptives are those which contain the hormones the female hormones, and they are further classified as those which are combined, typically the pill or combined oral pill, but there are those which contain progesterone only method. The combined oral pill contains both estrogen and progesterone, which is made in varying quantities, meaning each tablet in those pills has different amounts of the hormone, and it is an attempt to mimic the changes that happen normally during the month. And because of that modification, then these combined pills preserve the ability to get periods when somebody is using them. Whereas when somebody is on the progesterone only pill, the periods can actually disappear. They become, the menses disappear. Also, because of that particular attribute, then this combined pill can be used to regularize hormones for women who have hormonal imbalance. And I'm sure some of us might have had this suggestion from their providers where you are given combined pill either to restore menstruation or to regularize hormones. On the other hand, progesterone-only method as a contraception exists in various formulations, which include the pills to be taken daily. We have injections, which are given every 3 monthly. There are implants, which are put under the skin. And locally, we have one which lasts for 3 years and another one for 5 years. And those are the brand names. But also we have a kind of contraception called Mirena, which is put in the womb, but it is laced with some progesterone. So it also serves as a contraception among other uses. This progesterone-only method typically alters the cervical mucus and make it non-conducive for sperms to thrive, and therefore prevents chances of conception. Usually, if you want to initiate contraception for somebody who has given birth before the baby is 6 months, this is the method of choice because it does not interfere with the breast milk production. Are there reasons why somebody should not use hormonal methods? Of course, yes. Ladies who are hypertensive, ladies who have had a history of blood clots or who are at risk of blood clotting, there is a relative risk in women who smoke, and then persons with the placement of pacemakers in the heart, other congenital or acquired heart conditions, then persons with bleeding disorders, ladies who are obese, because as we shall see later, these hormones also tend to cause weight gain. Women who have had a prior history of stroke, it's a relative contraindication or reasons not to use. And persons who are taking other medications which might interact and interfere with the effectiveness of this contraception. And a good example are ladies who are taking medicines against tuberculosis or TB. So some of the reasons why side effects for these hormonal contraceptions, as I've said, include weight gain, particularly because of changes in metabolism and water retention in the body. There are ladies who will develop high blood pressure when they are put on hormonal contraceptive. And for those who are taking progesterone only, they might experience menstrual abnormalities. The periods can disappear or become heavy, or actually it can become irregular. There's also increased risk of blood clotting, as I mentioned earlier, in patients who are at risk. The other effects of hormonal imbalances may also manifest, which include depression, mood swings, among other manifestations. Yes, the other category, as I started by saying, is the non-hormonal methods. And we have two types of non-hormonal methods that exist. And these include the barrier method. We are conversant with the both male and female condoms. It is good to emphasize here that these condoms are manufactured either from latex or rubber. And apart from conferring protection against unwanted pregnancy, it offers dual protection because it can also protect against sexually transmitted infections or STIs. The other non-hormonal method is intrauterine device, which is loosely called a coil or IUCD. This is a plastic device which is coated with copper and usually placed in the womb. It protects against conception by altering or changing the environment within the endometrial cavity or the uterus. And we have an image to show for those who have never seen how it looks like. So it's a very small device. You can see it has a plastic part and some copper coating. And when it is placed, it appears as shown in the diagram on my right. It is placed right at the center of the uterus. It remains there. It doesn't dislodge, and it offers protection. Most of them will work for a maximum of 10 years. So they are very good for use in persons who cannot use hormonal methods and also in persons who prefer long-term contraception. Next. There are other methods which are contentious and people use them. We have varied opinion, professional opinion about this because they tend to have a high failure rate, as mentioned. So the rhythm method means avoiding intercourse during the times when you perceive that the lady is fertile. And therefore, it means by avoiding intercourse, you eliminate that risk of conception. People use these enabled by either counting days for people with regular periods, but nowadays there are apps which are available to track the so-called fertile period when somebody can abstain or avoid exposure. There's a method called coitus interruptus, withdrawal method, which means the male actually avoids ejaculating inside, and therefore they are not able to cause conception. It has a high failure rate also because any careless move, you can expose the lady to unwanted pregnancy. I think these two are self-explanatory. Perhaps I will respond to any concern that may arise. I didn't feel the need to belabor that. Next one. We have a special category of contraception, which is called permanent contraception. The initial term which was used was sterilization, but it has more or less negative connotation. So the term we use currently is permanent contraception. These are irreversible methods which can be adopted in the following cases, among others: when the pregnancy is not desired at all, there are people who know they don't want to have babies at all. When somebody has reached the desired family size, where there exist reasons to completely make it impossible to conceive, like women who have terminal diseases or those very serious diseases like heart conditions, kidney conditions, liver failure, etc. And it is thought that if they conceive, they are likely to get overwhelmed and probably even die because of pregnancy. We also have certain cases where some men or ladies may manifest profound mental disability, and therefore, based on that, it can be a reason why relatives actually take them for this intervention. Because such people, if they get babies or conceive, you can imagine what will happen. So the method used for males is called vasectomy. Again, not a very new term for most of us. And this entails cutting or blocking the ducts that transport sperms and therefore prevents sperm emission during ejaculation. Then the female bit is called bilateral tubal ligation, which means you tie and cut the fallopian tubes. There's an illustration of what is done. Again, not very graphic, but the image on my left, you can see there's the tubes which normally carry the egg after ovulation. So they are cut, they are truncated, they are cut, and you create a discontinuity so that the egg has no way of traveling and meeting the sperm. On my right, there is also an illustration of vasectomy where the two ducts are connecting the testes to the rest of the system are actually severed or cut off. And that means the ejaculate doesn't have sperms even during intercourse. Yes, this is also a contentious bit on emergency contraception. This is typically not a contraceptive. So most of the time we mention it to condemn it because it carries quite a number of risk factors. So in this case, the lady is exposed to high levels of contraceptive hormone, which is progesterone. And this is in a desperate measure to prevent conception. In cases such as rape or defilement for kids who are less than 18 years, that is the term that we use. When the primary method is in doubt, for example, you were using a barrier method and then the condom breaks or spills out. In situations where someone has had unprotected intercourse and pregnancy is not desired, it is good to note that this method works best if it is taken within 12 hours or even sooner. The longer somebody stays, the higher the chances of failing. And there has been shown to have some value if it's taken within 72 hours. Thereafter, taking this kind of emergency pill is more of a psychological treat. It's not, it doesn't work because by then a lot of processes will have taken place. Again, due to the side effects which I have highlighted and high failure rate, emergency contraception must only be reserved and used strictly for emergency, not as a routine contraception. The last bit I want to mention before we look at some of the myths and misconception is what is the process of selecting the most appropriate contraception, because it is not everyone who can use any method, as I've explained. One, it is important to take proper history, meaning you inquire into their medical conditions, allergies, any previous experiences, so that you don't expose them to contraceptive, which might worsen the condition if they have, or which is likely to fail, as I have explained in the previous slides. Consider the desired duration of contraception. There are people who want to prevent conception for a month, 3 months, 1 year, 5 years, and others forever. So be sensitive and pick the method which favors the recipient. The other thing is any previous experience should be considered in case somebody has had a previous undesired interaction or reactions, side effects, or complications. They should not be ignored. We also consider availability of the method, affordability, because they cost money, unless you have access to the freely available ones in the government facilities. You also consider access, both geographical and in terms of money. And I would give an illustration, like if you're dealing with the people who move from place to place, the nomads, or people who are not stationed in one specific place, you have to consider, if you start them on this method today, are you able to get them in the next few weeks or few months to replace? Will lack of replacement contribute to failure? Then consider the component on acceptability, because there are certain methods which are generally not accepted across board, and people have different reasons. So you don't ignore that, and we consider. That is based on personal preference in as much as it is medically sound. In other words, you may choose a method which we feel is likely to cause problems to you. Then it is upon us to explain to you why you can't use it and guide you to use an alternative method. Next. So from the foregoing, these are some of the highlights. One, each person must be considered to decide what fits them. There's no method which fits everyone. Secondly, careful assessment must be done on what is called medical eligibility criteria, and such must be documented during the discussion. It's also important to involve the partner. If you're dealing with a male, involve the female. If you're dealing with a female, involve the male for acceptance, and also to dissuade them from having a lot of unnecessary conflicts. So it takes two to tangle. That's what we tell clients. Number three, avoid permanent methods for persons who are too young, who you suspect probably they may not understand the full scope, or the ones who are evidently not decided on whether they want the method or not. Because it might be agonizing when later on they want to reverse the method. Then careful discussion of the options available, potential side effects, failure rates, and the aspect of resumption to fertility, which means the interval that it will take for somebody to conceive once the method is discontinued. Next. So what are some of the myths that exist about contraception. One, there are people who believe that contraceptive cause infertility, and actually they do not, because the effect they have on the body is usually reversible. It may take a bit of time, but it is reversible as long as you are not using a permanent contraception, which we said is vasectomy or tubal ligation. The second thing, misconception, is contraceptives can cause cancer. Again, not true. There has been no link between these two, which has been proven scientifically. So that's also a myth. Some people also say that contraceptives can cause recurrent miscarriages. Not necessarily true, because there are ladies who have had miscarriages even without ever using contraception. So that demystifies that particular myth. Contraceptives can also cause low sexual drive. Again, this is not entirely true, because this drive is a combination of many factors. So it is possible if somebody has stressing factors, maybe stress at work, stress at home, or if they are taking certain medications, it is very easy to attach that observation to use of contraceptive. So that is also a myth. Contraceptives can cause babies to be born with anomalies. Again, that is not true. Because as I said earlier, these methods have been developed over years, even way before we were born. And therefore, it is not factual that they are associated with abnormalities. Abnormalities can happen even in persons who have never used contraceptives. The other myth, again, contraceptives can cause heart attack. This is not entirely true. We tend to see this in persons who are using contraceptives when they have an underlying heart condition, partly because they have not been properly screened or assessed. And therefore we say avoid over-the-counter acquisition of contraceptives, because the person selling these drugs may not have a chance to assess and take a simple thing as your blood pressure, which might become worse when, especially, you start taking hormonal contraceptives. The other myth is contraceptives must not be given to children or minors. I think one of the questions I get asked often is whether use of contraception by young people will affect their future ability to conceive. We have said that these effects are reversible and they wear out when the method is discontinued. Again, use of contraceptives in minor and people who are younger than 18 is more of a societal and I believe problem, in the sense that there are people who believe when you start these kids on contraceptives, you're in essence encouraging them to engage in dangerous sexual activities. So it is not true that they will not have kids when time comes. As a matter of fact, if we expose them to unwanted pregnancies and some of them will go and terminate them, you are likely to jeopardize their future chances of conceiving when time comes. So it is a discussion that there is no straightforward answer, and you will not get someone to tell you this is what to do, this is not what to do. But it is always good to have a very candid and constructive discussion with this cohort of people without resorting to threats or intimidation, because from where we sit, we have seen that these often do not work. In fact, they cause more problems. You encourage them to be rebellious. The last myth is that contraception, women should not receive, who are not getting their periods, do not need contraceptives. Again, not true, because we have seen women who actually conceive even when they are not receiving periods. Yeah, it is possible to be ovulating and not getting period, and therefore, in fact, we see this with women who conceive immediately after giving birth before their periods have come back. So always discuss with your doctor, with your healthcare provider, if you're in doubt, so that you don't end up in a crisis. Next. In conclusion, ladies and gentlemen, and I take note, we have quite a number of gentlemen in the talk. One, the role of contraception is very critical in maternal health. That means you protect women from getting babies when they are not ready or when their bodies have not recovered, for those who have had kids. So that recovery improves the outcome and the health of these ladies. Number two, contraceptives are a form of control. In other words, when you're in charge of your reproductive capacity, you are in control and you don't need to be getting babies anyhowly, and then you're in perpetual crisis. Also remember, every baby that you get, you need to give them attention, you need to protect them, you need to provide for them. Therefore, this form of control exists in human beings and may not necessarily exist in the animal kingdom. And that creates a huge difference. The last thing, these contraceptive methods, at least the ones which I've discussed, are highly researched and they pass for safety, and therefore they are approved. That is why they are given in both private, public sector, and the government supervision, because they are universal. The same method that you get here in Kenya is the same thing you'll get in other continents, the USA, Australia, other places, meaning they have been thoroughly researched, they have been improved over time, and their safety is assured. However, there are these interpersonal observations where you find you use a method, it doesn't work for you. That may not necessarily mean that the method has an issue. It's that unique interaction between yourself and the method, just like it happens with other medications. Even paracetamols, antimalarials, antibiotics, there are people who will have undesired interaction and side effects. On that note, ladies and gentlemen, I've come to the head of my brief presentation. I am hoping to have an interactive session where I can pick one or two questions and before we conclude. Thank you for your attention and thank you for remaining muted during the presentation. Thank you. Wycliffe, you can pick it up.
Yes, thank you very much, Dr. Thank you very much, Dr. Fred, and for that insightful and engaging presentation. I believe that we've learned a lot, and for us, for those who had some misconceptions about these methods, we've gotten some clarity on what the truth is. So with not much ado, I think the floor now is open to the participants. Let's make the session be interactive so that we may get more clarity on maybe some issues that we feel that doctor has not touched on. So I'll open the floor for questions. If you have a question, please raise your hand and I'll give you an opportunity to ask. To start us, I'm seeing on the chat, we have Lorna Okach and Maxine. So Lorna is asking, is a tubal ligation reversible? And on the same note, Doctor, Maxine is asking, can tubal ligation fail? Kindly, Doctor, you can answer those two as we wait for the others.
Thank you, Lorna and Maxine. One, initially we used to say tubal ligation is not reversible, but to some extent it is, and that is when you use artificial assistance in form of IVF. Nowadays, you can conceive without necessarily use of the tube, where the egg and the sperm are fertilized outside the body and the embryo is implanted. So to that extent, it is highly reversible. Of course, it costs money. It is more involving. Earlier on, there were attempts to repair the tubes which have been cut during tubal ligation. I must say that the outcomes are usually not very good, because when you repair the cut portion, it will heal and form a scar. In any case, it will increase the chance of getting an ectopic pregnancy, which means pregnancy comes and gets stuck at the scar, and therefore within no time, there is a rupture of that particular point and internal bleeding. So that is my bit on that. The other question related to that was, one was reversibility of the tubal ligation, and the other one was what? Quickly.
Sorry, the other one was is tubal ligation, can tubal ligation fail? And
Yes,
then
the other question. Remember, we said that. Let me answer that first. Remember, we said that there is no method which is 100%, because this tubal ligation is being done by a human being. Where there is a human being involved, there is always a human component as a contribution. The kind of tubal ligation that we do nowadays is different, because it also involves cauterizing or burning the head of those tubes after you cut, and that greatly minimizes the chances of reconnecting of these tubes. Otherwise, it is possible the tubes to reconnect and recanalize, meaning they form the channel. And we've seen, in my practice, I've seen around 3 which have failed. Again, that failure can be attributed probably to the method that was used, among other factors. Sometimes even the stitch that is used may allow the tubes to reunite. Wycliffe, there was another question.
There's another question. Lorna is asking, what is the success rate of IVF?
Again, partly out of scope of this, but I would say that the success rate depends on many factors, including the age of the person, the quality of the egg and the sperm, the local experiences at the fertility center. So those are things which can be discussed by the person, because it is not uniform to everyone. But the current local statistics we have is somewhere between 25 and 45%. Of course, it's higher among the younger cohort of women compared to the older cohort of women. And of course, women with the other comorbidities or other conditions may grossly minimize the chance. So that particular scoring or evaluation to determine the success rate is better discussed on one-on-one basis, because there are many parameters that are considered, including the hormonal profile, the body build, among other things, the ultrasound findings, yeah, among other things. I see an hand up from Yvonne Wamuyu.
Yes.
Is she able to unmute and ask?
Yvonne, go ahead.
Hi, I hope you guys can hear me.
Yes.
Yes, we can.
Okay. Yeah, apologies, I joined the meeting late. So maybe I have a question on the coils and the IUD. Is it a myth that someone with a short cervix cannot consider that option of family planning? And then recently, from other people's experiences with coils and IUDs, yes, copper, whichever, the one that has copper in it, they experience a change in their cycle, like extreme um pains, menstrual cramps, or uneven menstrual cycles. But from the uh, medical experts that I've listened to, they say it's supposed to last for like few months, but to some people it might extend to up to 6 months or even 1 month. So if someone experiences that reaction to those forms of contraception, how long would you advise someone should monitor the body for those symptoms? And after how long should one withdraw from the contraceptives in case of those extreme side effects? Thank you.
Thank you, Yvonne. That's a very good question. There are many variables that can make the coil not work. One, there are people who have allergy to copper, so they will experience a lot of cramping, a lot of discharge. And those are the questions we ask. There are also people who might get an infection when the device is being introduced or soon after. That can also increase the chances of bleeding, cramping, and pain. The device can also get dislodged. It can move. So when you have persistent pain after insertion, the best step is to have an ultrasound to confirm the location, because if it has moved, you don't only get the pain, but it also increases the chances of failure. And that's why you find some people actually presenting with a conception when the copper IUD is still there. It is true that people might experience some cramping and increased flow for a few months, which is expected to subside. The advice is, if it persists beyond 3 months, kindly have it checked. And sometimes we have had to insert the coil and remove it the same day, because there are people who cramp intensely and become severely affected that you actually remove it. You insert and the cramps are so much, then you remove. So these are the variations that I talked about, meaning that you might find your friend is on a coil and they're very comfortable. It doesn't mean that it will also work for you. So when you go to consult, the person will check. The other question was about the short cervix. It is true there are people who have short uteruses, but nowadays there are different devices. Some of them are shorter. They are designed for such kind of individuals, and so there's a commodity for each person. In fact, I've noted there are others which are not even in the usual shape. It's like a small ball which is placed in the uterus, and it has similar effect with the copper T, and it exerts that contraception effect. So always discuss that with the provider to ensure that you get what is favorable for you. Thank you, Wamuyu.
Thank you, Doctor. There's another question from Tony. He's saying that I saw a patient recently who had a IUCD, got pregnant, and later lost the pregnancy. What could be the cause? And then he continues by saying, when someone does abortion, not sure whether a medical abortion, then after that, periods aren't consistent and there is no HX or FPUs. what could cause that? Because she has tried several times to get pregnant again, and it's not happening. Ultrasound normal, and LTH tests was also normal. What could be the cause of irregular periods?
Sometimes it could be hormonal. Thank you, Tony. It could be hormonal compounding the problem. Remember, the body sometimes will pick that early pregnancy as pregnancy. So just the way it takes time to resume after giving birth, the people will take longer. But usually we advise, if there are those undue delays in conception, it is not good to wait, just consult so that at least you can have proper evaluation to find out what is causing the delay. Because there are many other hormones which may affect ovulation, including prolactin, low levels of estrogen, reduced progesterone, among other things. But also remember the intensity, and not the intensity, the frequency of intercourse, which is what essentially results in conception, sometimes may be less as compared to before. So it is always good to interpret everything in perspective, ensure that you are not missing out anything, and where necessary, perform investigations. Thank you.
Thank you very much. Kindly, if there is another question, you are free to ask. I'm seeing Tony also requested that we share the slides.
I think we will share also the presentation, because I believe it's being recorded. So yes, once we are done, we can share to their emails.
Thank you. And just a reminder, we usually do these health talks monthly. So we'll also, for next month, we're also preparing for the next month. Oh, I'm seeing Duncan has raised his hand. Let's hear. Hello, Duncan, kindly, you can ask your question. I'm seeing you've raised your hand.
Tanui?
Yes.
Can you hear me?
Yes, you can hear me.
Yes, my name is Duncan.
Yes.
I am a clinical officer.
Yes.
Are there CBD points for this meeting?
Sorry, Duncan, you're breaking. Your voice is kind of like... Yes.
Are there CPD points for this meeting?
Doctor, is...
Are there...
Duncan, unfortunately, there are no CPD points because we had not anticipated that.
Okay.
So we are not giving CPD points today.
Okay, thank you. We are very thankful for this wonderful insight and a form of CME for some of us.
Thank you very much. We invite you to join the next one as a weekly per week. Asante sana.
Thank you.
Natumai hatujafungia mtu yeyote nje. Kama kuna mtu ambaye bado ana swali anaweza uliza. Usibaki nyuma. Asanteni sana kwa participate kwa mkutano wa leo. Vile nilishasema, huwa tuna mikutano kama hii kila mwezi, na sasa tuna prepare for the next month. Hiyo mwezi wa September pia tutakuwa na ingine. Nawakaribisha wote. Kwa sasa niwashukuru tu wote kwa kuhudhuria mkutano wa leo, na niwawish tu jioni njema kwa wote, na sasa mnaweza left.